So let's briefly review, as we discussed, MEN2A and MEN2B have in common medullary thyroid cancer in 100% of patients, pheochromocytomas in 50% of cases, and some other conditions are different in between the two. So MEN2A is associated with primary hyperparathyroidism in 20%, while MEN2B is associated with mucosal ganglioneuromas in 98% of cases, and Marfanoid habitus in about 97% of all cases. Now, there are different mutations associated with each types of MEN2A syndromes, so we are not going to stop or spend time there unless you want me to, but we'll go into the next slide. So multiple endocrine neoplasia type 2A has 3 different variants that are important to consider in clinical practice. So in MEN2A, we have the classical MEN2A families that have, again, medullary thyroid cancer, that have pheochromocytomas, and that have primary hyperparathyroidism. But there are some variants to those families. One of the variants is what we call the familiar medullary thyroid carcinoma variant, in which the families develop medullary thyroid cancers, but they never develop pheochromocytomas, and they never develop primary hyperparathyroidism. We have the cutaneous leakingamyloidosis variant, which is just associated with codon 634, associated with that skin lesion that I showed to you before, and we have the Hirschsprung's disease variant. So let me show you examples of the 3 of them. So what is a familiar medullary thyroid carcinoma? This is a classical family with familiar medullary thyroid cancer. This is a family from Brazil. It's quite large. It's a complicated slide, but if you look at the black areas, those black groups of people are people who have developed medullary thyroid carcinomas. As you know, it follows an autosomal dominant pattern, so different generations have been affected by the disease, and they have never developed pheochromocytomas. They have never developed primary hyperparathyroidism. An interesting aspect that is important take-home message for now is that for most part, familiar medullary thyroid carcinoma variants exhibit a better prognosis than the classical MEN2A phenotype. So they do a little bit better. The Hirschsprung's disease. The Hirschsprung's disease is associated with mutations exclusively located in exon 10. They are in codon 609, 611, 618, and 620. Now, what is important here? These mutations, for the most part, may predispose to either multiple endocrine neoplasia type 2A or familiar medullary thyroid cancer, but in some families, they predispose to a Hirschsprung's disease variant. So you may see in these patients that there is a loss of the autonomous nervous system ganglia located in the distal part of the colon. The rectum is obliterated, as you can see in this slide, and you will see dilatation and megacolon in these patients once they are born, and you can see it radiographically speaking. Now, look at the example here. One mutation may give you, in different types of families, a different phenotype that belongs to the same category. In other words, you can have classic MEN2A associated with 620 in some families. You can have Hirschsprung's disease with MEN2A in some other families. You have just families who only exhibit a familiar medullary thyroid carcinoma with the 620 mutation. So that's one part that could be confusing. So the history of the family is going to be very important to tell you to which variant your family belongs to. The second variant that is important of multiple endocrine neoplasia type 2A, or the third variant, I'm sorry, is the cutaneous leakingamyloidosis. Another example. This one has a much more pronounced skin lesion located in the upper part of his back. There is no mortality associated with it. There is morbidity given by itching in that area, and this is associated only with codon 634, and only a few families that carry 634 res mutation will have this particular skin lesion. Now, this one we reviewed on MEN2B, so I'm going to skip this slide. And we are going to a phenotype that we didn't see before. This is the classical Marfanoid habitus phenotype of patients with MEN2B. Again, the patient has a low setting of his ears. You will see ganglioneuromas in the eyelids, but very important, the upper and lower extremities are disproportionately long when compared with the central part of her body. And if you look at her hands, you will see the classical spider deformity characteristic of patients with MEN2B. As we have described, the red gene is characterized by the expression of a protein that is tyrosine kinase that has an extracellular domain rich in cysteine in association with an intracellular tyrosine kinase domain, and it's in these domains that we are going to see mutations that predispose to MEN2A and MEN2B. MEN2A mutations are located in the extracellular domain as well as in the intracellular tyrosine kinase domain. The ones that predispose to MEN2B are exclusively located in the intracellular tyrosine kinase domain. The red, in their normal conditions, in order to become active, has to be dimerized, as we have described before, and the presence of the mutations may either facilitate the dimerization process, which is what happens in MEN2A, or simply activate a single protein, which is what happens in MEN2B. And again, that is likely the explanation for the aggressiveness that we see associated with this particular disease. This is a complicated table, and I want to just spend maybe a couple of minutes here for you to understand the concept that I have mentioned to all of you before. One mutation in a particular codon in the same exon in one family may give you a different phenotype from the same mutation that we see in another family. Why is that? We don't really know how to explain that phenomenon. What it is clear from this table is that when you look at mutations that cause the multiple endocrine neoplasia type 2B, which in this table are represented here by mutations in red 918 and 883, these mutations will never give you multiple endocrine neoplasia type 2A, will never give you a familiar medullary thyroid cancer phenotype, will never be associated with a Hirschsprung's disease, will never give you a cutaneous leakingamyloidosis. So this is the most obvious differentiation in between the different types of mutations. Now, if you look at the mutations that we have causing MEN2A, there are mutations in codons such as 609, 611, 618, 620, as well as others. These mutations in some families can give you familiar medullary thyroid carcinoma. In some families can give you a predisposition to pheochromocytoma, giving you the classical MEN2A syndrome phenotype. What is the implication of this? As we are not able to differentiate in between the two, we have to look at the families. And if the families exhibit a case of familiar medullary thyroid carcinoma, you may classify it like that. Saying that, as in most of these patients, we don't have a long-term follow-up and it's difficult to differentiate, it is important in all these patients to do a screening for pheochromocytomas, regardless of the presence or not of a history of pheochromocytoma in that particular family. So that's important. So for patients who have familiar medullary thyroid carcinoma phenotype, please do a screening for pheochromocytomas with measurements of plasma-free metanephrines or urinary fractionated metanephrines in a 24-hour urine collection. In particular, if you are considering surgery for these patients, it's very important to have the patients prepared for surgery of medullary thyroid carcinoma, having the pheochromocytoma corrected before. Now, familiar medullary thyroid carcinoma variants sometimes, or in many cases in reality, are not associated with an MEN2A classical phenotype. And those variants are, for instance, the ones located in exon 5, exon 8, and some of the ones located in exon 10, such as the mutations in codon 600, 603, and 606. These are families that are not predisposed to pheochromocytomas. What is the meaning of this? That in the context of MEN2A, most of patients have the classical phenotype of MEN2A that is given by mutations in 634, which happen in about 85% of cases. However, in the number of genes that are mutated, there is more variability in genes that are mutated that predispose to familiar medullary thyroid cancer than what you see in MEN2A cases. When you look at Hirschsprung's disease, there are some families who have those mutations, and again, cutaneous leaking amyloidosis only happens in some mutations located in codon 634. Just to remember, again, the aggressiveness of the disease depends on the medullary thyroid cancer type of gene mutation the patient may have. Again, the American Thyroid Association classifies mutations in risk A to D, depending on the severity of the clinical phenotype, being A the most benign, D the most aggressive. Now, remember that the A is considered more benign. It doesn't mean that it's to underestimate. Patients who belong to category A may have cancers that if you underestimate spread to distant places and you may not be able to treat them or cure it ever. And as we discussed, there is an association with the lymph node and metastatic disease presentation. Now, let's talk about the age of prophylactic thyroidectomy just based on that, as we have mentioned before, and this is just a reminder because it's very important to keep in mind when you have mutations in category D, 918 and 883, you need to do a prophylactic thyroidectomy as soon as you identify the patient. I wanted also to mention here an important aspect that has not been discussed. Multiple endocrine neoplasia type 2A usually has a family history that tells you that the patient has a predisposition for it. Multiple endocrine neoplasia type 2B may have it or may not have it. 20% of patients with multiple endocrine neoplasia type 2B are de novo presentation. So in other words, they didn't have any of the parents affected by the disease. And many times these patients are seen by pediatricians, dental doctors, ophthalmologists, and they don't recognize the clinical manifestations of the disease. So it is not unusual to see in clinical practice patients with MEN2B in whom the disease is advanced. That's one of the big problems we have with MEN2B. However, if you have the clinical intuition, or if you are able to identify the particular family, always remember, consider a total thyroidectomy by as soon as possible, usually by age 9 or 10 months after being born. Remember that for category C, before age 5, you may consider a total thyroidectomy. Category B and category A, you may discuss, you may negotiate with the family when to do it, depending on how safe they feel and how comfortable they are from a cultural and social perspective in regards to having their child with hypothyroidism because of a total thyroidectomy. Now, some words about pheochromocytomas. This is a meeting on thyroid, a parathyroid disease, but in the context of medullary thyroid carcinoma, we need to know about pheochromocytomas. So as we have described, pheochromocytomas are neuroendocrine tumors that are coming from the adrenal medulla. In patients with MEN2A and MEN2B, the pheochromocytomas only occur in the adrenal medulla. They are never extra-adrenal. So when we focus our studies and our efforts in looking for a pheochromocytoma, anatomically speaking, our efforts are focused in the adrenal medulla. We don't need to look for other places of paraganglia. In other words, patients with multiple endocrine neoplasia type 2 are not prone to develop paragangliomas or extra-adrenal pheochromocytomas. They are exclusively located in the adrenal medulla. An important characteristic of the pheochromocytomas of these patients, from a biochemical perspective, they produce both adrenaline and noradrenaline. So when you do the biochemical testing, you will see an increased expression of both hormones. So both norepinephrine as well as norepinephrine will be elevated in plasma. Now, what it is important is that not all mutations are associated with pheochromocytoma development, and this is a slide that is going to show you an example of those. So, in the right side of this slide, you will see this is the largest study published on pheochromocytoma in MEN2A and MEN2B. We have 233 patients who didn't have pheochromocytomas, and in all of them you will see all kinds of mutations that are associated with that particular clinical phenotype. And in the left side, you will see a cake with 85 patients who have pheochromocytomas, and only a few mutations were associated with that particular disease. Which are those mutations? 69% of these mutations are located in codon 634. So 634 is the one that will give you a higher predisposition for pheochromocytoma disease. In 17% of patients, we didn't know what the mutation was. In 8%, 6918 was another important mutation associated with disease, and rarely we saw it associated with 883, with 618, and with mutations in the gene or codon 666. So pheochromocytomas are much more selective as a disease. The age of presentation of pheochromocytomas in these patients varies a lot depending on the mutation. When you have a mutation in 634, it may go from age 15 up to age 60. After age 60, you may not need to screen pheochromocytoma that often, but you have to start screening for pheochromocytoma as soon as age 15. For mutations in 618, they happen later. For mutations in 918, they may happen at a very young age, around age 13, age 14. You may see the development of pheochromocytomas, and again, you have to do the screening for pheochromocytomas early in these patients. Now, pheochromocytomas are frequently bilateral, so the adrenal glands can be compromised both together by this particular disease. Unilateral disease happens in 28%, in 72%, however, is bilateral, and synchronous disease, meaning two pheochromocytomas at the same time, happen in 82% of cases, while metachronous disease, one pheochromocytoma first than other, happens in about 18%. And the difference in between time, in between one pheochromocytoma and the other, may be in between 1 and 2 years, up to 20 years of difference. In other words, once you detect a pheochromocytoma, you have to screen the patient for pheochromocytoma periodically in this particular category. What is the most important clinical implication? How do we treat pheochromocytomas? With surgery. What kind of surgery we have to do for these patients? Try to do a cortical sparing adrenalectomy. Never remove the adrenal gland completely. Leave part of the cortex because you want to protect the patient from the development of adrenal insufficiency. Patients with multiple endocrine neoplasia type 2, type 2A, and type 2B, whenever they develop a pheochromocytoma, must be treated from a surgical perspective with a bilateral cortical adrenal sparing adrenalectomy. Very important concept to keep in mind because the disease is bilateral, and to deal with adrenal insufficiency is not easy. Now, going back to medullary thyroid carcinoma. In most patients, the diagnosis of medullary thyroid carcinoma happens first. That's very important. In occasional patients, you will see that the pheochromocytoma is diagnosed first than medullary thyroid carcinoma. So some patients with MEN2 may present with apparently sporadic pheochromocytoma. What is the meaning of that? That if in your practice you see someone who has a pheochromocytoma, and that pheochromocytoma is apparently sporadic, and the pheochromocytoma is associated with a phenotype of both adrenaline and noradrenaline production, you may order gene testing for the red proto-oncogene. That's an important implication here. Now, in several patients, the diagnosis of medullary thyroid carcinoma and pheochromocytoma happens together. The implication of that is that when you see a medullary thyroid carcinoma, you order the gene testing. If you are not able to order the gene testing, please order plasma metanephrines or 24-hour urine fractionated metanephrines, regardless of the fact that you know or not if the patient has MEN2A or MEN2B. And if you see elevated metanephrines in plasma, do radiographic studies, look for the pheochromocytoma, and first treat the pheochromocytoma before you treat the medullary thyroid carcinoma. The medullary thyroid carcinoma can wait. The pheochromocytoma is for most part benign, but it can give you a lot of complications during surgery of medullary thyroid carcinoma if you miss it. So that's an important aspect here. So when do you do the testing for pheos? Start at age 15, measure plasma metanephrines or 24-hour urinary fractionated metanephrines every year until age 60. Then after, you may do it every 2 to 3 years. If positive, consider CT or MRI of the abdomen. And again, for surgical perspective, consider a cortical sparing adrenalectomy. So with this, I'm going to finalize this conclusion, and in that sense, I recovered the 20 minutes that we have occupied from the previous lectures. So what are the conclusions of this? And this is to close this area. Red testing is very important because it allows to classify MEN2 syndromes. It may determine clinical manifestations, clinical associations, a familial phenotype. It predicts aggressiveness and prognosis of medullary thyroid carcinoma. It helps to indicate the time of a prophylactic thyroidectomy, identify individuals in the same family at risk. It determines treatment, and this is perhaps the most perfect example in oncology of primary prevention of cancer. Here, when we do gene testing, we are able to treat cancer before the cancer is even developed in the early stages, which is something that you don't see, for instance, with the screening for prostate, breast, or cervical cancer, which are other common cancers in clinical practice. And with this, I finish this presentation. Thank you.